My name is James Dom Dera. I'm a family physician from Akron, Ohio, home of LeBron James, the world's greatest basketball player ever. Also home of the birthplace of Alcoholics Anonymous. And also the Akron experiment, where we first learned that adding iodine to salt prevents goiter. So there you go. There's some useless knowledge for you today. Just drop some knowledge bombs on you. I'm a family physician, and I have two roles in my life. I'm a full-time family physician seeing patients in the office 5 days a week. And the stuff we're going to talk about here today are things that I actually do in my practice. I am also the Advanced Primary Care Medical Director for NewHealth Collaborative, which is an accountable care organization based in Akron, affiliated with Summa Health. And my role is to help practices in their transformation efforts. One of those efforts are things like risk stratification. I have no disclosures here today. Here are our objectives. So we're going to talk about a two-step approach to risk stratifying your entire patient population using a combination of objective and subjective data. We're going to talk about doing that in a very structured and algorithmic approach involving your whole care team. And then we're going to get into a little bit of change management as well. And then if we have time, we'll talk about how many games the Cleveland Browns might win this year, perhaps. They haven't lost yet. They haven't won yet either, but they haven't lost yet. But first, let's talk about risk stratification. So here we have two patients, one of whom has arthritis of the left knee. The other has rheumatoid arthritis of the left knee. Knowing nothing else other than that, osteoarthritis versus rheumatoid arthritis, who would you predict would have more complications in the future? One has osteo, one has rheumatoid. All right, the rheumatoid arthritis patient. So rheumatoid arthritis not only destroys the joints, it has effects on the body outside of the joints. The treatments for rheumatoid arthritis, the DMARD therapies, are expensive, have a lot of side effects. So knowing nothing else about your patient other than rheumatoid versus osteoarthritis, you'd say probably that rheumatoid arthritis patient has a higher risk for complications in the future. Let's do another one. Two patients, one of whom takes a birth control pill. She's a 24-year-old, let's say, comes into your office. She's only on a birth control pill. The other one is that patient who comes into your office with a garbage bag full of medications. Medications and supplements and herbals and vitamins and old meds. She even has a prescription of Valium in there for Fluffy, her dog. Like, she has everything in that bag. So knowing nothing else, we would probably say that patient with the polypharmacy is the higher risk patient. Let's do one more example. Here we have two patients. Both are diabetic, on insulin, with an A1C of 7.8%. Now who do you predict has the higher complications in the future? Well, it gets a little trickier now because everything I just said is the same for both patients. We need more information. So it turns out that that person on the right just lost her job. She lives in a food desert, so she doesn't have access to affordable, healthy foods. She's not going to be able to afford her insulin for much longer, and she's probably going to be evicted here soon. So now, knowing that, here again, I think we can say that that's probably going to be the higher risk patient that we deal with. What we just did was two-step risk stratification. We just sorted patients into high versus low risk groups based upon the objective and subjective data that we know about our patients. That's the heart of what we're going to talk about, is sorting patients into higher versus lower risk groups based upon the things you know about them. Now, this is not a new concept, by the way. You've been doing this for a long time. So for those of you who are clinicians in this room, you don't screen every single patient who walks through your doors for hepatitis C. You screen those who were born between 1945 and 1965. So you've said, hey, this is a high-risk group. I want to screen those patients. Or you don't give every patient in your practice a Prevnar PCV13 pneumonia vaccine. You say, give me the patients who are 65 years and older and under 65 for certain conditions, and I'm going to give them this pneumonia vaccine. So for a long time, you've been sorting patients into groups and managing them accordingly. This is just a more formal way of going about that. And in this formal way, we're going to sort patients into one of 6 different levels. Level 1, the lowest risk patient. Think of that 24-year-old who comes in for a pap test. She's otherwise healthy. Her weight is normal. She exercises. She doesn't smoke. Versus level 6, catastrophic care. So that might be metastatic cancer or a hospice patient. That's the patient that there's just a lot going on. We're going to sort patients into one of these 6 different levels. We're going to do this for every single patient in your practice. So if you were to pull up a list of all your patients, everybody's going to have a number next to them. So Mary Smith, 5. Tom Smith, 2. LeBron James, 1. Like every patient is going to have a risk score attached to them. We're going to look at an algorithm to do this. Now, by the way, 6 levels of risk is arbitrary. There's nothing magical about 6 levels of risk. There are a lot of practices. I know of a good practice in my area that sorts patients into 3 levels, essentially high, medium, and low. I know of a practice that uses 7 levels. You could have 77 levels. It doesn't matter. Essentially what you need is some way to sort patients into higher versus lower risk groups. This 6 levels of risk, by the way, comes from the American Academy of Family Physicians Risk Stratified Care Management Rubric. So the AAFP developed this years ago. If you're an AAFP member, this is free for you. If you're not, it's $50. It's a copyrighted tool, so I can't show it to you here today. But it's a useful tool for sorting patients into one of these 6 different levels. What this tool doesn't tell you is how do you get there. The one we're going to look at here will in a moment. Here is the goal. Ultimately, the goal is this. Higher risk patients require more resources. So, I think all of us right now could sit back and think to one of our patients in our practices, the ones that kind of just make you put your head in your hands. They require a lot of resources. They go to the emergency department more often, they come in the office more often, they see more specialists, they're on more medications. Higher risk patients require more resources. So this is a way for you to identify those high risk patients and then eventually, which we'll touch base a little bit on, manage them differently. Okay, let's look at the algorithm here. Here is the 2-step risk stratification algorithm. And if you're like most people, the first time you see this, you kind of have this reaction to it. Because it's lines and colors and boxes and shapes and, like this is really going to make my life easier? I doubt that, right? So it's really not as complex as it sounds. We're going to step through it bit by bit here. Essentially on the left-hand side is step 1, objective risk stratification. And on step 1, we're going to sort patients using objective data into one of 3 different levels, high, medium, and low risk. This is a pre-sort. Before we go on to step 2, where we're going to refine their risk into those final 6 different levels that we talked about. So let's look at this individually. Here is step 1, objective. I'm going to blow these data points up so you can see it better. Step 1, objective risk stratification, where we're using data that we can measure, data that we can run a report on, we can press a button for, data that people don't disagree over. So we're all going to agree that an A1C of 9 is considered high, for example. We're going to use some sort of objective data to pre-sort these patients into high, medium, and low risk groups in preparation for step 2. So if your EHR, for example, produces a risk score, which some do, you could use that. If a payer gives you a risk score, you could use disease metrics. You could say, hey, I'm going to call everybody with COPD on oxygen high risk. And maybe I'll call everybody with COPD medium risk, and everybody else is everybody else. You could do that. You could use claims-based data. So show me everybody who's been in the ED 3 times or more in the past year. That's going to be my high-risk group. Ever what you want to do, it's just objective data that sorts patients into higher versus lower risk in preparation for step 2. So the middle group is the middle group and the low group is the low group, right? So it's just sorting them out that way. So for example, here's a report I run on my practice saying, give me everybody who has an A1C greater than 9. So here's the practice, here are the diabetics, and here's the A1C greater than 9. So now we got this nice little package of high-risk patients that we can then take and further risk stratify through step 2. You could do other things up there that you see, using claims, data, Patients not seen is one that's kind of useful to use. But whatever you want to do, some sort of push button, run a report to get me information about patients. This data, by the way, may not come from you. Your payers may provide that data for you. So you may get reports from your payer like I do, where you get on your desk, something thrown on your desk that says, hey doc, here are all the patients who are due for a mammogram or a colonoscopy or that we consider high risk. So you could use other sources of data to calculate step one. If you do HCC scores, which are the high-risk ICD-10 codes, you could use those to find your higher, lower, and medium-risk patients. I mentioned that payers will give often risk scores. There's a payer locally that uses Truven, one of their population health analytics platforms, and generates a risk score. And it's a proprietary risk score, but still they generate that, and you could use things like that. What you can find some sort of objective data to sort patients into high, medium, and low risk groups in preparation for the next step. Now, by the way, you could stop here. You could stop here, and you would effectively have sorted your patients into high, medium, and low risk, and then you could go from there. The advantage of objective data is that it's objective. It's easy to get to. You can push a button, and there it is. It also allows comparison from practice to practice. So me and from Akron, Ohio, and a provider here in San Diego could both, if we agree on the criteria, compare our patient panels, and it's apples-to-apples comparison because we've agreed on the same criteria. The problem is objective data is not always available. So if I'm going to rely upon claims data, for example, somebody who was in the emergency department 3 times last month, I'm not going to see that on a claims report until 2019, as of right now. Objective data may not be accurate. So again, for those of us who have gotten that report on your desk that says, here are all your patients who are due for mammograms or colonoscopies, how many times is that 100% accurate? Because if you're like me, you're about 1/3 of the way through the list, and about 1/3 of them are wrong, and I throw the rest away, right? It just gets frustrating at that point. But more importantly, objective data doesn't tell the whole story. So here I've mentioned before a couple times A1C greater than 9 is high risk. I'm sure all of you know of patients of yours who have an A1C greater than 9 that aren't really high risk. They're doing okay. Maybe it was 12 last year, and it's 9 now, and they're exercising and they're taking their medication, so they're actually doing pretty well. Or maybe they're 92 years old and it's 9, and I don't know, it might be okay. But you know, so it just, the data alone doesn't tell the whole story. We need to further refine this, and that's what step 2 is, subjective risk stratification. So these 5 diamond-shaped boxes going diagonally down the screen are a series of 5 questions that you and your care team can ask yourselves to sort patients on one of those 6 final levels of risk. And it's kind of a, you know, if you ask one question, if you answer that yes, okay, you're done. If no, go to the next, then go to the next, and go to the next, until you finally get to the last question. So let's go through these. The first question, would you be surprised if your patient died in the next year? I know that sounds kind of harsh at times, but it really does encapsulate that, because we all know of patients that we say, you know, if you were to get a phone call at 3 in the morning, or when you get back to your practices next week and you find out that one of your patients passed while you were here, and you say, I wasn't really surprised. She was suffering. It was her time to go. That was probably a level 6 patient. But if you say no, I'd be surprised. So let's go to the next question. Does your patient have complications of their chronic disease? So maybe they have end-stage renal disease on hemodialysis, or they have COPD that's requiring oxygen. They have behavioral health diagnoses that are out of control. That could be a level 5 patient. And so then you go to the next question. You say, well, no, my patient really doesn't fit that category. So let's go down here. Does your patient have chronic disease with out-of-range markers, but no long-term complications? So there's your A1C greater than 9 patient, for example. Now, you know, I say out-of-range markers because out-of-range is very specific. You know, we set patient-specific goals. So maybe a patient of mine has an A1C target of 6.5. So for them, an A1C of 7.5 will be out of range. Versus that 91-year-old, maybe her A1C target is 8.5, in which case she's okay. So it's very much patient-dependent. And if we say, no, we're still not there, let's go to the next question. This is going to be kind of the average patient for those of us who see patients in the office. This is going to be that they're on medications, they have chronic diseases, but they're stable. Think of the hypertensive, hyperlipid, diabetic patient you see over and over and over again. That's going to be probably a level 3 patient. And then the final question is your patient healthy but they have out-of-range biometrics? They're overweight, for example, right? That might be a level 2 patient and everybody else is a level 1 patient. So those 5 questions sort patients into one of 6 different levels. And if you noted, those are still kind of quasi-objective. They still don't capture everything. And that's what this little white box in the corner that I've circled in gold does. Those are our escalation and de-escalation criteria. So these are the other questions that you and your care team can ask to kind of further sort things out. It's your gut feeling. You know, one of the nice things about family medicine is that we see the entire family. So often we know when there's a problem in the other part, one part of the family that's impacting somebody that we're seeing right now. It's the social determinants of health. This is where this comes into play. But it's that last one, that gut feeling, that's there. You know, every day we see patients at 7 in the morning. We start seeing patients at 7, which means by 6:45 we're in our huddle. Which means at 6:30, my medical assistant is leaving the gas station with a cup of coffee. So she was telling me this story. This is over the summer or late spring. So she's at the gas station, finishing up her getting her cup of coffee, and she sees one of our patients. He doesn't see her, but she sees him. He's standing at the counter looking at the cigarettes, like lovingly. Like if he were an emoji, he'd be the heart eye emoji, okay? And so she comes back to the office, and we started talking about him. And this is a guy that we'd seen since for a long time, but had a couple COPD exacerbations this past winter. They're ambulatory exacerbations. Never went to the ED, never went to the hospital, just treated in the office. And winters in Ohio are tough for patients with COPD. But maybe he started smoking again, and that's the reason why. That was enough for us to raise his level from a 3 to a 4, for example. It's just things like that. It's just your little bit of knowledge that you have around your patients. I mentioned the social determinants of health. The American Academy of Family Physicians has a great tool around screening for social determinants of health called the Everyone Project. This is free for everybody. Google Everyone Project. And it's a series of screening tools that you can use to screen your patients for social determinants of health. So things like, what's your housing situation? Yeah, I have housing. Or no. I kind of go from person to person. Sometimes I sleep in my car. Sometimes I sleep in the park. How about your food situation? You ever run out of food? Yeah, sometimes I run out of food during the month. It's questions like this. And probably the most important question, do you want help with any of this stuff? I always get nervous when I see that question. I recall when we first started screening patients for depression, and my MA would come and tell me, you know, so-and-so in room 7 has a positive PHQ. You know, my first thought was, can you go back and ask them those questions again? Because I got a really busy day and I don't have time to deal with that. Until you kind of realize that, you know, you're not going to fix the real problems until you address that. So this is the same way, is that you're not going to really fix their problems until you address their social determinants of health. Here again, the AAFP has a tool available for you. It's called a Network Navigator. So Google that one, Network Navigator, Everyone Project. And you just put the patient's zip code in. And up comes a list of hundreds of resources that are available to you in your area for your patients for these things. Okay, let's get back to the algorithm. This is just another way of restating it. We're going to take patients and we're going to dump them into that funnel on the left. That's the left, right? Yeah, the left. We're going to sort patients into one of 3 different groups, high, medium, or low risk, based on objective data. We're going to then take those patients and then drop them into the second funnel and sort them by subjectiveness into one of those 6 final levels, level 1 to 6. Level 1 is the lowest, level 6 is the highest risk patient. By the way, you may not always have objective data available, in which case you're just going to jump straight to step 2. And you may not have the subjective data available, in which case you'll just do step 1 and kind of take your best guess. For those of you who've, in the course of your careers, have learned how to read EKGs or learn how to read X-rays, at first, if you recall, it's a very structured process. You see an EKG and you say, okay, that's the rate, the rhythm, the axis, and then the P, and the PR. If you go through this whole process in order to come up with an answer. Eventually, you can look at an EKG and say, oh, that's AFib with RVR. Or you say, oh, that's a right bundle branch block. Same with risk stratification, is eventually you're going to find yourself saying, oh, that's a level 3. Oh, he feels like a 5. Right? You're just going to get it. You're just going to know because you know your patients best. Here are some examples. I've borrowed this from a colleague of mine, Dr. Matt Finneran. If anybody knows Dr. Finneran in Wadsworth, Ohio, great family physician. He and I have very similar patient panels, so I borrowed this from him, which is a nice way of saying I stole it from him. Although he gave me permission afterward to steal it. But this is just an example of what, for my patients in my practice, what a lot of these patients look like. So for example, if you have a patient who is stable thyroid disease or on levothyroxine, their dose hasn't changed in years, they come in once a year, you get TSH, maybe that's a level 2 patient. CKD stage 4 or 5, or COPD on oxygen, or poor social determinants of health, that might be a level 5 patient for you. Now here's the good thing about this is you're going to tailor fit this to your practice. So maybe your practice is in a college town and you see a lot of young families and young people who the disease burden is low, so your level 5 patient's going to look different than that. Or maybe you're in an urban environment where those social determinants of health are really driving a lot of what goes on in your practice. Then it's going to look different than that. So you're going to build this however it works best for you, because you know how to take care of your patients best. You know your patients best. That's the key. Integrating your clinical intuition into your risk stratification is the way you identify your high-risk patients. Integrating your clinical intuition, that gut feeling, is how you identify your high-risk patients. If anybody went to the behavioral health integration lecture this morning, you heard a little bit of this where they were identifying kind of high-risk patients for their diabetes interventions, and they set a criteria of A1C greater than 8, and then the next piece was, and anybody we think needs it, right? So that was subjective and objective approach. They were integrating their clinical intuition in this. That's how you identify your higher risk patients. Okay, so you built this algorithm. Who's going to do this? And the answer is everybody and anybody. So you could, for example, have a care manager, and they come in on a Monday morning, they click a button, they say, okay, give me everybody who's a diabetic greater than 9. There's my list of high-risk patients. And then they take that list and they go to step 2 and start to funnel it through that list and sort patients into the final 6 different groups. They could do it that way. Providers could do the same thing. So as you're doing your pre-visit preparation, getting ready for patients, or as you're in the room with patients, you could look and say, okay, they have heart failure stage D. That's probably high risk. Let me see how they're doing, and you assign them a risk score. Your entire care team could do this. This is how we started in my office. It was kind of a wild west of risk stratification. Everybody assigned a risk score, from the check-in person to the medical assistant to the provider to our PA. Everybody did it. And in order so we didn't have 7 different risk scores for one patient, we just kind of set a rule that the provider kind of got the final say-so. But everybody could do this. You could do this during team meetings, so your weekly team meetings or your monthly team meetings, whether it's your whole office or your individual team, often called the teamlet, right? So your little teamlet meetings or your entire office could come up with a panel of patients and say, let's look at every patient we've seen for the past 2 weeks, or let's look at every patient we're going to see, and go through this process to do it. I think the huddle is probably the ideal time to do risk stratification. Remember, the huddle is a work stoppage. We're going to talk about patients. It's not a mini staff meeting, right? We don't say, remember, Martha's retiring next week, so bring a covered dish on Tuesday. That's not a huddle. A huddle is talking about the patients of the day. What a great time to talk about risk, right? Because you're having robust clinical interactions about your patients. We can throw risk in there. So in my office, we have a checklist that we do for our huddles. Just like when you were flying out here, the pilot, she had a checklist of how to fly an airplane. We'd go through a checklist every day, every huddle. And the last item on the checklist, risk levels. So we have to do it. That's part of our huddle. And we've gotten to the point now where not doing risk stratification feels weird. Just feels weird to do it. Okay, let's talk about some change management a little bit here. So from a change management perspective, what you want to be able to do is go back to your office to make change that sticks. What you don't want to do is you go back to your office next week and you say, hey guys, I heard this great presentation at the NCQA Conference. I cannot stress how great that presentation was. He was super handsome, by the way. And let's all do this. So you start this process up, and then by January, you kind of do it, and by next May, nobody's doing it. Right? We want to avoid that from happening. We want to start this process and keep it going. So I think we're all familiar with Kotter stages of change, which are kind of the 8 steps you need to do to affect change. If you do this for anything, whether it's in healthcare or in business or industry, you will affect change and keep change going. So Kotter's a good way of looking at change. It's a little bit academic. I don't think it translates well down into the trenches. Most of us are familiar with the PDSA cycle, Plan, Do, Study, Act, or Plan, Do, Check, Act, if you do it that way at your institution. So it's the, what do you want to do? Go do it. How did it go? Keep doing it, right? It's the Plan, Do, Study, Act. And by doing multiple Plan, Do, Study, Acts, you can affect change. So Plan, Do, Study, Act, and Kotter kind of overlap a little bit because they're all about steps you need to do to affect change. So multiple PDSA cycles over and over again are what you need to do to kind of push that boulder up the hill. You do multiple PDSA cycles over and over again, and that will affect change. That's a tool for change management. The other term for this, continuous quality improvement, right? CQI. This is just that. But if you do multiple PDSA cycles, you'll help to drive change forward. Now, the last stage of Kotter is that one, the institute change or the make it stick part. You got to do something to make it stick. You got to have something in place that after you've done each cycle, that you've now hard-baked it into your processes or your workflows or your policies so that you can't go backwards. You have to have something there to make it stick. That's one of the other keys in doing multiple change cycles, is you have to have something that stays around afterward. In my practice in 2017, we decided that we were going to formally risk stratify every patient in the practice using this approach that I've just shown you earlier. We set a goal of doing all patients by April of 2018. We got mostly there, 90+%, so it was okay. But we did pretty well. And so as I mentioned, we first started off just everybody risk stratified, kind of a wild west of risk stratification. And that worked somewhat, but then we moved to huddles. And we put it during the huddle, risk stratification during the huddle, and that worked really well. In fact, so well we said, let's make it stick. So now we added a checkbox to the checklist for the huddles, and it said risk levels. You got to do it now. You can't not do it. And then we moved to the next piece, which we're going to touch base here in a little bit, which is risk stratified care management. Let's manage our patients differently because of their risk. That was our next make it stick. So by doing those things, you effectively drive change forward. Multiple PDSA cycles with something that makes it stick are a way to drive change forward. But the effectiveness of your change is a function of quality and acceptance. So here again, you go back to your offices next week, you say, guys, I got this great approach for risk stratification, heard this awesome lecture, I cannot stress enough how handsome that guy was, like movie star level of handsome. Anyhow, that's beside the point. But great program. And while you're telling your staff all of this, they're sitting there, they're looking out the window, or they're filing their nails, or they're playing Candy Crush, or they're Googling Dom Dera handsome, or something like that. They have no real interest in this. So their acceptance is low. Quality is high, acceptance is low. You're going to have very low effective change. And vice versa. If everybody's just jumping up and down happy, wants to do something, but you don't have the proper strategy in place, it goes nowhere. That's another way of saying culture eats strategy for lunch every day. So you have to have the culture of change in your practice. You have to have everybody is on board with always looking for ways to improve things, always looking for doing the next PDSA cycle. You always have to have that in place. If you don't have that, you will not drive change forward. Now there's a limit to this, by the way. You can only try to get so much buy-in. It's easier to act your way into thinking than to think your way into acting. So it's easier just to do it and get going with it. So for example, you may go back to your practice now and you may say, guys, we're going to start risk stratification. During our weekly team meetings over the next 6 weeks, we're going to talk a little bit about risk stratification at each meeting, and then on November 1st, we're going to start. And And so you're going to work on effectiveness, you're going to work on the acceptance rather, but come November 1st, you're doing it. You're going to hit that go button, whether everybody's ready to do it or not. That is another way of saying the Nike model, the just do it model, right? Sooner or later, you just have to do it. You just got to press the button and go and get it in. Okay, let's talk a little bit about practical applications. We're going to finish a little bit early today, so we'll have time for questions at the microphones there. But as we go back to the slide that we saw previously, high-risk patients require more resources. So let's identify those patients that are higher risk, and then we're going to proactively manage them. So this could be an entire presentation by itself. But this is essentially risk-stratified care management, where we're going to do things differently for each patient based on their risk level. So if we look at just access, for example. Here again, next week, you're back at work. A patient calls up with a chief complaint of a cough. So imagine that's a level 1 patient, that 24-year-old who came in early in the year for the PAP test, versus a level 5 patient, COPD on oxygen. Okay, chief complaint of cough, level 5 versus level 1. Those are two wildly different visits right there. So that level 5 patient, you're going to act differently. That's person you're going to say, I need to see them right away. And if I can't see them, my partner can see them, or the PA or NP or somebody needs to see them, but we need seen right away. And by the way, everybody, when you bring her back, let's get a pulse ox, and usually when she gets here, she runs out of oxygen, so let's get the oxygen tank ready, because she's going to run out, you know, all those things. You're going to do all that for that level 5. That level 1 patient with a cough, you got a cough. You try some Mucinex, right? I mean, just let's see how you're doing. This is a great place, by the way, though. I mean, not to downplay the significance of her visit. That's a great place for your alternative visit types. So maybe you're going to do a web encounter with her, or if you have some telehealth, you can do some sort of video conferencing or Skype visit with her, and maybe save her a trip into the office. If again, we're thinking value-based care, not volume-based care here. So that's a great way. So if you say, I have a resource called alternative visit types, where am I going to deploy it? Well, you might deploy it more toward that lower end, that lower acuity sort of thing. From a resource management standpoint in your office, this is very useful for smaller practices who have limited amounts of resources. So when I think of my practice, it's just my partner and I seeing patients, and we're part of a larger ACO, so we have some resources available to us, but we don't have the ones that the large practices do. We have a behaviorist in our office 1 day a week. She's a social worker who does disease-based behavioral health interventions. Her name is Amanda. So I would love to have Amanda see every single patient in my practice. I would love to have a bunch of Amandas 5 days a week. I don't. I've got her 1 day a week. So we say, Amanda, here's a list of level 5s. Let's go through these and see who you need to see. So now, as a small practice, I've more efficiently distributed my resources as opposed to saying, whoever walks through the front door is going to get this resource. And obviously things like care plans and goals of therapy change for your level 5 patients. Your level 5 and level 6, level 4s, it's all about preventing secondary and tertiary complications and palliation of disease versus the low end of the spectrum, which is about preventive health and keeping them from getting disease. So care plans look different. Everything looks different through this. Before I came here this week, we got our first shipment of flu shots in. It's like 280 flu shots. And it really, like, this warmed my heart, because before I could say anything, my office manager said, and I've already sent out a mass message to all the level 5s. Right? Because who needs the first set? Like, they're the ones who need it. I mean, I need my flu shot every year, but I can wait. I'd rather somebody else get theirs first, and then I'll get mine later. That is risk-stratified care management. So we were treating patients differently based on their risk levels. We can't do that unless we risk stratify them. And that's the key with this. So here we are at the NCQA Conference. And just to touch base quickly, just by doing risk stratification, it's going to make it easier for you to achieve some of these cores and credits. So I picked my words cautiously there, because I can see beads of sweat building up on NCQA people in the back. What I'm not saying is if you do risk stratification, you automatically get credit for all these things. But if you do risk stratification and go the next step, risk stratified care management, you'll have a much easier time when it comes to trying to find a way to get points here. Okay. Right now, Hurricane Florence is battling against the Carolina coast, and it's just, the devastation is immense. And I know all our thoughts and prayers are with our friends and family and colleagues there, because hurricanes are devastating events. This is Hurricane Mitch. Hurricane Mitch hit the Honduran coast in 1998. To this day, it is one of the strongest hurricanes in recorded history to come out of the Atlantic Ocean basin. This was a Category 5 storm, and it roared ashore. Every single bridge in Honduras was either damaged or destroyed by Hurricane Mitch, except for one, in the little town of Choluteca. In Choluteca, bridge was fine. The problem was that the river moved. Within the course of a few hours, the hurricane carved a new courseway for the river, rendering the bridge obsolete. Be the river, don't be the bridge. Carve a new courseway for your patients. Do things better for your patients. Make things better for your patients, for everyone else, and be willing to throw away the old way for it. All right, we finished up early. Thank you for your attention. We have microphones available for questions or concerns. If anyone wants autographs, you can come find me. If you're going to throw something at me, by the way, warn me so I can duck, because I can't see it come with the lights. Yes, sir.
First of all, go Warriors. Do you use a care manager, and do you have the care manager focus on your rising risk, your 4s and 5s, versus your 6s, which in our practice are kind of the, I don't want to say waste your efforts, but putting a lot of effort into them that are, like you said, you might think, wouldn't be surprised if they're dead in a year or in a nursing home or something like that, that maybe your efforts are better spent at the rising risk rather than the high risk.
Correct. So the answer is yes. In my mind, there are two forms of care management. And this will maybe go to the, if we ever talk about risk stratified care management in more detail, we'll talk about this. But there are two types. There's episodic care management and there's longitudinal care management. So episodic is that episode. It's an event. It's for unplanned care. It's for transitions of care. It's for crises. We have an RN care manager that we have available to us because we're a part of an accountable care organization, and she focuses on those patients. So those are the higher risk patients, the 5s and the 6s. And then in my office, I have a care coordinator. It's one of our MAs who was actually out on sick leave for a while. Then when she came back, she couldn't really do as much as she could do in the past. So we just transitioned her job title, and we call her a care coordinator. And so her job is to focus on more the 4s and 5s, maybe the high 3s, and do a little bit of rising risk. Obviously, the rising risk population is huge. If you took 100 high-risk patients, and we fast forward a year from now, there's only about 70 or 80 left, because some got better, some died, right? So you only have 70 or 80 left. So the next year, you have less, the next year you have less. So you have to focus on rising risk, or else the pool of patients you're focusing on is just going to dwindle to nothing. So sooner or later, you have to do rising risk. Yes. Question?
I have two. I work with the New York City Health Department. We provide technical assistance to, it's 2018, so I Googled you while you were talking. We provide different kinds of support to organizations of a similar size to yours, smaller family and internal medicine practices. One thing that we come up against when we talk about risk stratification is that it's a lot of thinking and a lot of work, and sometimes we don't get to the end because there isn't really enough of an impetus. What was it that pushed you over the edge that said we have to do this for all of our patients now?
So I'm going to give you two answers to that. One of which is it's just the right way. It's like a lot of things we do. It's when you start screening patients for depression that it's a lot of work up front. We screen patients for depression, we screen them for anxiety, we screen them for fall risk. It's a lot of work up front to do that. It's better in the end. But up front, there's much more work to be done. So one of the reasons we do this is because it's better. I always tell the staff, my staff gets nervous when I come back from a meeting or a conference, something like that, because they always say, oh my God, what idea is he going to have now that's going to change things? So here's what happens. At first, the workload goes up. At first, patient satisfaction, but certainly provider satisfaction and staff satisfaction goes down. I call that the vortex of suck, right? You're just, initially, after you start changing things, you get stuck in the vortex of suck and everything sucks. But if you stick with it, now you've offloaded all that work. You've front-loaded it now. You got it done, so when the level 5 patient shows up, you're ready for her. So for example, this is part of our longitudinal care management, we reach out to every level 5 patient ahead of time. And we call, hey, Mrs. Smith, you have an appointment with Dr. Dom Dera next week. We got a second? Can we just go over all your medications, make sure anything has changed here? Do you need any refills while we got you on the phone? Since you were here last, have you seen any other providers, right? Have you gone to the hospital? Have you gone to the ED? Answer all those questions, gets documented in the chart, and guess what happens when I walk in and see the patient? I'm much happier because all that stuff's been done. So that's a lot of work up front, but eventually what happens is your workload during the day becomes much easier. Now here's part 2 of my answer is we are part of CPC Plus, which is a nationwide demonstration project by CMS around primary care transformation, and we're required to do this for CPC Plus. But here's the whole point. We were doing this already, we just made it more formalized. And it's made all of our lives much easier, to the point now where going backwards seems weird. Like every now and again we'll see a patient without a risk score and it feels weird to us. We're redesigning our schedule right now, so level 5s have so much time, level 2s have so much time. You have to have a risk score for that. It'll feel weird not to. So we do it because it's the right thing to do, which is ultimately that's the reason all of us are doing PCMH work. We're not doing this to get rich, right? We're doing this to take better care of our patients because it's the right thing to do. It's a lot of work.
And my second question is really, really quick. I know you're a family provider. Do you have any pediatric patients who found their way into an upper risk level, or that's?
So that's a good question. We're like a lot of primary care practices that our pediatric population has dwindled over the years. Okay. So the pediatric patients this is just for my practice, by the way, that we have left are primarily young, healthy kids. So I can think of just a handful who aren't level 1s or 2s, but almost everybody is. But you could easily adapt this to a pediatric practice or a family medicine practice doing a lot of pediatrics or however.
Thank you.
Thank you. Question?
Thanks for the great presentation. And I just had a question back to your flow chart. In order for a patient to make it into that subjective risk stratification, must they be yellow or red on the objective? How does that work?
So that's a good question. And so the answer is no. So for example, if I have a patient who on our first step objective risk stratification is more of a high-risk patient, they're probably going to end up higher risk on the subjective part. It'd be very rare where somebody has high risk by whatever objective criteria, let's say A1C greater than 9, and we assign them a very low-risk score, 1 or 2. So that's why I say it's a pre-sort for you. But there are times when that data is not available, you just jump straight in and just say, I think they feel like a 3. Now here, this is why I tell the staff all the time, there is no right answer to this. This risk stratification is for our own internal use to manage our patients better. We don't report this out to anybody. It doesn't affect our payers or our payments or HCCs or anything like that. It's just for us to manage it. So if we're wrong, it's all right. That's okay. This is not about assigning patients risk scores that are stuck with them forever. And that's the other piece, is risk scores change quickly. So they could be a 4 today and a 6 tomorrow because of what happened. That's one of the last patients I dealt with before I left to come out here, was somebody that my final conversation with my MA is when she said, I think he should be a 6 now. Yeah, I think he should, right? Because a lot was going on. So it'll change, it'll make its way through there. And it's all just essentially a grand approximation.
All right, thank you for the presentation. I had two questions. What platform do you use to record and report your risk scores?
So we use eClinicalWorks. I wish this was like vodka to answer that question, because my love for eClinicalWorks just would fill this room. So anyhow, I should have just said unknown horrible EHR. So forget what I just said. We use unknown horrible EHR, okay? And so, listen, no EHR was ever designed for what we are doing, which is chronic disease management. EMRs are essentially glorified billing tools. They're designed to capture data. They're designed to capture data in a SOAP note format, essentially, which is stupid because chronic disease doesn't follow SOAP notes. Subjective, I have diabetes. Objective, you have diabetes. Assessment, diabetes. Plan, diabetes. Like, what the hell, So we use eClinicalWorks. We have workarounds in place so we can store risk scores in the chart to make them visible and also make them trackable. But they're workarounds.
Okay.
eClinicalWorks has a tool, by the way, that will calculate a risk score for you, and it's like all our EHRs. It calculates that based on objective data, so it is what it is.
Okay. My second question, for the huddle meetings, are you using a Google survey tool?
For the huddle, you said?
Yes.
Yeah, that's a Google form, Google Doc, and so we don't put patient names on it, so it's HIPAA compliant. So it's a Google form, so I can track it, and I do. And I go back and I track it, and we get nice little data around who's using the form during huddles and who's not, and everything else. So we use that.
Okay, thank you.
Okay, thanks. I have a question to actually expand a little bit on the previous question. We use ECW as well.
Yeah, I'm sorry to hear that.
We're trying to create a provider incentive program that includes a risk score. So I'm really looking for where you are placing that risk score in structured data that would be trackable and reportable to yourselves. So you could actually look at somebody's panel and say, oh, okay, well, they have, and I realize it may change, but actually to watch that over time, do they have more 5s or 4s? So where would you put that in ECW?
So if you, I'll give you a quick answer. But if you want to follow up with me, like email me or follow up with me offline. But we do it two places. We have a global alert that shows up. So if on the right panel or everywhere else or in patient schedule, there's an alert that shows up. And then in the patient info screen, you can build some structured data in that side of it. So you can go in there and store the risk score, and it stores it as structured data. So right now, if you said, give me every level 3 patient you have, I can click a button and do that because it looks at that piece of data. Now, I got to store it in two places. If one of them changes, I got to change both of them. If we're going to do click counts here, it'll make my head explode. So it's not an ideal answer. But here again, I'm not sure any EMR was designed to do this. But follow up with me and I'll send you examples. All right, any final questions, comments, concerns?
I know your practice is probably a little smaller, but say for a hospital that deals, or a health system that deals with 10,000, 60,000 patients, what would you recommend? A homegrown based approach for risk stratification? Say you have your own SQL report writers, Excel spreadsheets, or would you try to convince that system to purchase a third-party software? And some of the pitfalls on either of the two, what would you recommend? Thank you.
So that's a great question, because I think every week, I'm sure like everybody here, you get some sort of randomly solicited email from the world's greatest population health platform that exists, or such and such a system has just changed over to this or that. I mean, ultimately, you can use something like that, but still there has to be an element of the clinician's intuition of risk, of what they think. So ultimately, down at the practice level, so here's your huge health system, but still, you don't manage patients at the huge health system level. You manage it provider by provider. Atul Gawande said the most powerful tool in medicine is the physician-patient relationship, or the provider-patient relationship. That's the most powerful tool. It's not AI or platforms or any other shit like that. It's all about the provider. I'm getting worked up on that, I'm sorry. But it's all about the provider and the patient together. That's what makes the difference. So somewhere, no matter what platform you use, there has to be a mechanism in there that somebody can adjust the fine-tuning knob. Right? For those of us old enough to remember TVs and radios with fine-tuning knobs, somewhere there has to be a mechanism. So it probably doesn't matter whether it's a homegrown or something out of a box. But as long as you have the ability at the provider level to say, the computer said they are level 19, but I feel they're really level 23, and somebody has the ability to turn that knob a little bit, then whatever you choose works.